again, thank you so much, Beata, and also Chara Ruth, that you invited me to present a little bit about immunodeficiency. And our program is becoming more and more involved with adult immunodeficiency disorders. So one of the reasons why I was excited to come to you is to talk about the overlap between medicine and our immunology program. We have a lot to offer. Our patients come to our St. Pete Clinic, but if they need to be admitted, they're going to be at TGH. So one of my other selfish reasons to do this presentation is to connect. So if one of our patients is in the hospital, you would know who to call and what questions to ask. Sometimes the medicine program is they're learning and they are interested, but not always as deeply invested as we are, since we are the primary team for these patients. So this is sort of in a nutshell of who we are, and I will have a little summary slide of all of our actions and enterprises. So you're gonna see a bit more of the view of like what immunology is about here in St. Pete.
Thank you so much. And our specialties, I mean, between allergy, immunology, and infectious disease, we really have so many areas where we overlap. But I'm so excited for this relationship. I'm hoping, and this is for our fellows who are listening, I'm hoping for us to participate in Dr. Walter's clinics as an elective rotation, and also host Dr. Walter's fellows in our rotations, because I think it's just so important in infectious disease to have good basis in immunology, because of how much we have in common, really, and how much we share patients without even realizing it. So this is great opportunity. Please, my fellows, ask questions even throughout the lecture or at the end, because I'm very excited to inaugurate this relationship between the two fellowships.
Yes, and I am also hopeful that maybe your program can give presentations to us about how you see the patient population that you are facing, what is immunodeficiency, primary or secondary, what are your challenges, and how you solve the problem, so we can learn from that as well. So I think it's going to be a great conversation.
Absolutely. We would be delighted and honored.
Thank you. So let me know when you would like me to start.
I think it's 8 o'clock. Dr. Ehler, are you ready as well?
Yes, please begin when you are ready.
Thank you.
So I think I don't need to introduce you, Dr. Walter, but this is Dr. Walter. She is the division chief of allergy and immunology. She's a friend of mine, and she graciously agreed to talk to us. We've been talking behind the scenes to establish a relationship between our fellowships, and we are just absolutely honored and delighted to have her here. So thank you.
Thank you. And I'm very interactive, so unfortunately I cannot see you all at this point, because my computer screen has all this presentation mode. But I hope at some point we will be able to meet up and see each other. I would love to get people stop me during my talk and ask questions when it gets above your head or you think it's not clear. Please ask me to rewind and explain it more, because the whole idea is to deepen the knowledge of our fellows and also to ignite new conversation on attending levels about what we can do for this growing population of immunodeficient patients. And I'm going to talk about primarily on the genetically coded immunodeficiency disorders, but we are getting into the era where we have lots of patients with secondary antibody deficiencies because of CAR T-cell therapy or other interventions. And when we need to ask a question whether this patient had a genetically coded disease or they just acquired it because of the process, it's very hard to answer it after the fact. So what we try to encourage our specialty colleagues in other specialties is to consider immune evaluation as early as possible. And that way, when things go wrong, they would have a better understanding of how to move forward. So what can USF offer in immunology? We have several clinical cohorts. We are a Jeffrey Model Center network, which means that we provide immunology care of patients of all ages. And this is a global network. So our data is collected globally and presented by the Model Foundation. We do a lot of federally funded, investigator-initiated and sponsored research, and we are proud to have NIH funding under our umbrella. We are really excited about multidisciplinary approach, and this is the reason why I'm really excited about this talk. And we would like to connect with hematology, oncology, rheumatology, and GI, as our patients often require a very joint collaborative work to optimize their care. And then we are the part of national and international networks for investigations. So currently I have affiliations at the Moffitt, and I would like to grow that affiliation. We had a joint immunology BMT clinic before the pandemic, and I hope at some point we can revive it. I'm also division chief at Johns Hopkins Old Children, so we have strong connections to Baltimore, and then here at USF Morzani. Plus, our national society, the Florida Allergy Society, just gave us a small grant to create a hotline called Ask the Immunologist. And this hotline aims to help private physicians in the area who have patients who have immunological aspects of complications or disease, that they can call us and we can advise them about diagnostic workup, possibly discussion on treatment options. And this is a new era where we really have to work in a network. We can no longer just take care of our patients on our own. We have to be connected to maximize their care. So this is actually a paper that I published in 2019, and it sort of depicts how we see immunodeficient patients. You probably think infection is important, and truly it is important, but there are 4 other little circles here that can shape the patient's immune phenotype. Some of our patients have very severe allergies. They can have significant autoimmune disorder, inflammation, or lymphoproliferation. And what is interesting is that as we are learning more about immunodeficiency on the genetic front, we realize that some of our patients will not come with the infections first, and around 1/3 of the patients who have immune dysregulation, such as ITP and cytopenia, can have an underlying immunodeficiency, and that could be the first warning sign. So we no longer can say that infection is the only warning sign, and I will mention that later in my presentation. So what will happen to a patient is that they have a tendency for an immune disorder because it's genetically coded. And then you will have environmental triggers, irradiation, viral infections, also medical treatments, biologicals and steroids that will eventually create this diverse clinical presentation, also by time, because they don't declare a disease immediately. It sort of comes in sequences. And then when we have this very complex clinical phenotype, then we have to decide how we're gonna decipher it. So now we use a lot of functional immune studies, and we also do next generation sequencing, and that is becoming more and more of an upfront approach. And eventually, when we are fortunate to diagnose the immune defect, we can treat the patient mechanistically based on very specific pathways, and we can justify bone marrow transplantation. So I think it's extremely important that we have this initial diagnostic step as early as possible in the patient life, and therefore we can maybe avoid some of the complications that I listed here, and also we can bring them to treatment much earlier. So this is the current PID classification as of 2021, and I have put down the reference here from Stuart Tanguy. We have over 430 genes linked to immune deficiencies, and there are 9 main categories. I'm going to go through them a little bit because I think it's important that we all hone on these important categories. Of course, the most severe form is called severe combined immunodeficiency, and in this case, you have a T and a B cell deficiency. That's number 1 on the list. And we are fortunate to have a newborn screening program in the United States for these patients. So we find them in an asymptomatic stage, and we transplant them around 3 months or 4 months of age with a much higher, better outcome than in the past. Then we have other combined immunodeficiencies that are sort of syndromic, and one of the examples is the George syndrome. We also have Wiskott-Aldrich, ataxial telangiectasia, hyper IgE syndrome, and these patients, besides having a T and B cell defect, would have additional features that are very unique. We can find them on clinical findings, we can find them on immunological testing, and they also require high level of care. So these 2 categories here are extremely vulnerable patients. We have to find them in time and treat them properly. Now we are moving to the right side, number 3, which is the predominantly antibody deficiency syndromes. And that's probably what you will all see the most. These patients can have some level of antibody deficiency. We will discuss it in detail later. And I just put here 2 examples, XLA and CVID, mainly for the board of the fellows. XLA has full absence of immunoglobulins, whereas CVID has a diagnosis definition when you have recurrent infections, low immunoglobulin G in combination with A or M, and low vaccine titers. So it's very much of an umbrella term. And then we have other type of antibody deficiencies that I'm not going to discuss in detail because of time, but you have to consider in different ages of the patient. And as you are moving down further, the disorders are going to be maybe less common, but just as important. And I would like to highlight number 4. This is a group of disorders called diseases of immune dysregulation. And this group is rapidly growing. I will present it to you what is happening in our center. And these patients are the one where cytopenias and lymphoproliferation, arthritis could be potentially the first presenting symptom, and they may declare their infections and other complications later. So we have to be very vigilant about this group. Then we have CGD patients. I'm sure you take care of some of them in your own program. And this is, again, a very unique group of patients. We will discuss it because of the type of organisms that we isolate in these patients. And as we move forward, these are going to be less and less for your care. However, I must say that in the defect of the innate immune system, WIM syndrome is unique because these patients have a really high tendency for warts, and these warts could become cancerous at some point. These patients have a combination of neutrophil defects with lymphocyte defects, so you sort of cross over to hematology again. And our group has been heavily focusing on this syndrome, and we are learning a lot about disparities in care of these patients. There's the autoinflammatory disorders, familiar Mediterranean fever, and others, complement deficiencies. And the last group that I wanted to emphasize is the phenocopies of PID. This is what many of the medicine folks will be seeing, patients who are not born with an immunodeficiency, but they acquire it with age, and some of them are related to autoimmune disorders presenting as immunodeficiency. For example, chronic mucocutaneous candidiasis is now linked to unique antibodies that are going to make the patient be more susceptible to yeast infections. And we can detect these IL-17 antibodies in the lab and through other clinical labs. And that could be one explanation for your patient to have a new disease, whereas they had no problem when they were younger. And I also would like to emphasize here Good syndrome. Good syndrome is sort of close to my heart because I wear the name of Dr. Robert A. Good in my chair. And Good syndrome is still a not fully deciphered entity, but you find these patients, again, with a very unique presentation of worsening T-cell function, with tendency for bad herpes infections, hypogammaglobulinemia, thymoma, and many of them die early, like in their 50s or 60s, because we really don't know how to fully take good care of them. So this is just a little image from the same paper, which shows the dramatically increasing number of genetic disorders that are now linked to immunodeficiencies. And when we do that, we really can be much more targeted in our approach. So I'm just going to show you something more local, like some local information. 3 years ago, when we started to collect our Jeffrey Morrell Center information, we categorized all of the patients that we had at that time, and we had 750 patients. And as expected, many of our patients had antibody deficiency syndromes. And it is actually a bit less than the average in the nation. Most centers would have 75 to 80% antibody deficiencies. And I think because we are a referral center and we have a lot of complex patients, these other categories are growing a bit in our cohort. So then followed by severe common immunodeficiencies and the syndromic diseases that we just discussed, complement deficiencies, phagocyte defects. And I want to again emphasize this very unique group of dysregulation, which at that point was around 2% in our population. And as we move forward, I will show you how that has changed. So why is it important to categorize your patient? because there are certain disorders that we can take care of quite easily. For example, antibody deficient patients can have antibiotics, immunoglobulin replacement therapy, and if they only have a purely B-cell defect, they actually do quite well on that. Whereas if you think about syndromic combined immunodeficiencies or severe combined immunodeficiency, you now have to think beyond the antimicrobials and the immunoglobulin replacement therapy and very strongly consider bone marrow transplantation. And one of the key outcome that influencers of outcome in bone marrow transplant is infections. So the more infection-free the patient is, the more we can control all these viruses and bacteria in this susceptible patient, the better the outcome will be. Interestingly, when you think about phagocyte defects, again, I'm mentioning CGD at this point, it's very unique that they have a narrow spectrum susceptibility. And because of that, this whole antimicrobial prophylaxis is extremely unique and tailored. And these patients often require anti-inflammatory therapy beside the antimicrobial because they have a secondary inflammatory process because of the abnormal neutrophil function. And it's not uncommon that these patients also get transplanted in our institution. And looking at the dysregulation group, so that is actually the headache that we all have when we think of our patients who gives us the most worries or thoughts that we have to have. Those are the dysregulated patients. Because those patients not only need antimicrobials and immunoglobulin replacement, but they need biologicals. And biologicals were not very commonly used in our field in the past. We were very comfortable using antibiotics, immunoglobulins, even bone marrow transplant with the BMT team. But people in immunology were not using biologicals on a regular basis. And now we have to use them very specifically for this group. And we need to understand their side effects. We need to understand their indications. So this is basically an area that we are learning together with our fellows. So as of September 2020, just last year, you can see that the dysregulation group has already grown fourfold from 2 to 8%, and we haven't even accrued this year, but I'm sure it's going to be even a larger subset. And compared to that, the syndromic combined immunodeficiencies or severe combined immunodeficiencies has not changed much. So again, this is a group that I would like to put a lot of effort on in our discussion in the future. If I can come back and talk to you again, this could be an entire talk on itself. And I think it's important that infectious disease specialists understand the challenges of this group and help us to control that disease as young adults or in adulthood. So when I look at genetic diagnosis is on the rise. In the total population that we had, 20% of them had a genetic defined condition. And when you look at the most vulnerable patients, such as kids, severe combined immunodeficiency, the other combined immunodeficiencies, dysregulation, and phagocyte defects, we are actually doing a pretty good job in finding the genetic cause. So the genetic part is extremely important. And I'm actually just opening up it for a brief discussion with the fellows and your attendings. How often do you consider testing for a genetic cause for a patient that you are seeing for severe infections? Do you consider it, or do you generally have the immunology team decide about that?
Good morning, this is Dr. Morano. I just want to say a lot of our patients, we obviously take a really good history and we try to see if this happens in their pediatric life. I would say a lot of our patients have onset usually on the adulthood, but absolutely, if it happens in childhood, I think we see that it's either been picked up or we certainly consider it, but most of our onset that I've seen is really adult. So I think that's why we don't think about it as much, but I think there's, because it's adult onset, but I'll let other folks speak out. But yes, it's in the consideration, but most of it happens as an acute cause for us. And if it doesn't, it usually has been priorly diagnosed or we get it from the history.
Mm-hmm. Great. Any other comments?
Yeah, hi, Jolan. Thank you so much for being here.
Yes.
Yeah, we have seen quite a bit of some patients that we thought that it might be an underlying malignancies, that predispose infections. And with malignancy workup was unremarkable. I highly think of those to be could be late onset presentation of primary immune deficiency, and also any patient that had a lot of underlying unclear rheumatologic diseases, and those patients also I really urge for the workup. Recently, we had a very interesting patient. Juhi Kasman can share with you here as well. We have really had a patient in her 70s that has unexplained Cytosporium sepsis with brain abscess and everything. So this type of patient really need to have the workup, because I really think that anyone with milder presentation, they live longer now, and some of these diagnoses was not made properly when they were younger.
That is such an important point, and actually, I will give you an example of a young adult in her 30s who we diagnosed with a significant immunodeficiency, and this is a strong area of interest for us because, as Charlotte has said, sometimes there are hypomorphic variants that are just not as severe, and they may be lingering with the hematologist or the GI doctor. They don't have like really dramatic infections, and then after this immune dysregulatory phase, they start to declare more infections later in life. And then they're going to fall into your lap, and you're going to have a patient who already had several rounds of immunomodulation, and you have to decide how much do you think it's secondary to that, or is it an underlying immunodeficiency. And I think genetics can sometimes at least give you a peace of mind that, this doesn't seem like one of the bad genes or one of the bad diseases that you don't want to miss. So I think it's a great conversation, and I'm glad that we heard different sets of opinion, because we don't want to overwhelm your service either with thinking about immunodeficiency all the time. But there would be I think some presentations when you really want to go that route. So any other comments? This is great. So again, I think genetics is very important for targeted therapy and even justification for bone marrow transplant, which is becoming even more and more accepted in our field for adults. This is a global survey of how many patients we had at that time. 2 years ago, we had 750 patients, and a good fraction of them, around 20%, was on immunoglobulins, another 20% on IV, another 20% on sub-Q, and 34 patients were already transplanted. So when I think about what a fellow should know when they consider immunodeficiency evaluation, of course, we would like to have them to do a careful clinical history and exam. Who to evaluate, it's very important. You want to consider a basic immune evaluation and interpretation for those where you consider an immune deficiency, and that would be including antibody production testing, T-cell and innate cell function testing, and immune subsets. There are certain antibody deficiency syndrome that I think it would be great for the ID fellows to be familiar with. That includes XLA, CVID, specific antibody deficiency, and IgA deficiency. These are common entities, especially CVID and SAD. And many patients would need to be on immunoglobulins. And I have seen practices where the infectious disease doctor was the immunologist because there was no immunologist around. So depending on where the fellows will head out, they may have to become their really local immunologist for the patient. Management of infections, you guys are much better at it than us, but we need to know how to do broad versus narrow spectrum antibiotic therapy for an SAD versus a CGD patient. So this is a very interesting entity, and it could be a discussion on its own. And I'm actually very curious if you are treating adult CGD patients in your practice. Is there anybody currently followed by your practice for CGD? I'm not hearing anybody saying yes. So CGD is a disease that doesn't choose. Sometimes infectious disease doctors have to take care of CGD patients. In my first training program in Virginia at King's Daughters, the infectious disease specialist was a CGD expert. And I think taking care of a CGD patient can be extremely demanding because of the uniqueness of the organisms. So this could be like a feat to an immunologist or an infectious disease specialist to take care of. You have to be able to distinguish unique subsets. And I'm mentioning here a surface marker called CD45RARO. These are the naive versus memory markers of our immune cells, of the T cells. And this is a very simple test that could distinguish a patient who have common variable immunodeficiency from those who have combined immunodeficiency. And I did mention that combined immunodeficient patients are highly vulnerable. They have a T and B cell defect. So they could come down with a lot of non-infectious complications, malignancy, whereas a lot of the CVID patient, a typical CVID patient, do very well on immunoglobulin. So you want to sort of lift out from the crowd of CVID patients that you may follow, who is really the one who is combined immunodeficient. I think getting familiar with the newborn screening programs for SCID would be important. I certainly think it would be great for our fellows to be able to read an immune genetic report, and we practice that in our clinic. If you come over and spend time with us, you will be able to do that. And then you, more than us, consider causes of secondary immunodeficiency: drugs, cancer, biologicals, B-cell depleting agent, CAR T therapy, and immune checkpoint inhibitors. And there's a whole service in some of the academic centers, and I'm sure it's also in the Moffitt now with ID, where you have to look into these patients and decide how far are you going to go with their evaluation. If you think about an advanced level immunological knowledge in infectious diseases, it would be great for the fellows to learn how to order specific immune subset testing and NK cell studies and signaling defects. And in particular, I think recognizing the non-infectious complications of immune-deficient patients beside what they have, beside the infection, is very important to then be able to get to the right path, the right gene, and the right treatment. In the genetic front, we actually teach fellows on higher level how to interpret variants of uncertain significance and decide for or against a variant of uncertain significance to be related to the disease. And we want our fellows to learn by the end of the second year how to use mechanism-based therapies and how it could influence the prognosis of disease. We think that this is bridge therapy. In many cases, the patient needs to have bone marrow transplantation, but it could last for many, many years before the transplant decision is made. So, and I would love to get some feedback at the end of my talk from the fellows and even attendings of how should this list of ideal skill set apply to the infectious disease group, and is there something that you think we should take away from it or something that we should add to it? So when our fellows are cross-training with us, we could focus on more of what their needs are. So when to evaluate for a PID, and it's gonna. Oh, go ahead. Is there somebody asking a question?
Yeah, I'm about to add from your last slide.
Yeah.
I think that the expectation from ID specialists is really depends on the setting of the practice. If you are lucky enough in an academic medical center or close enough to those centers that have experts like you, we don't need to know in the advanced type of level. But if you practice in the area that don't have immunodeficiency expert, you probably need to know enough or a little bit more that can initiate certain things by yourself. So that's just my opinion.
Yeah, and again, I think that I'm definitely more infectious disease specialist than immunologist, because unfortunately our specialty is dominated by allergy. So whoever is going to private practice or not so much into the academic arena is generally enriching their practice for the allergy patient and less inclined to take care of patients with immune deficiencies. So it's not uncommon that these patients may fall into the lap of an infectious disease specialist who have to deal with their infections and some of their complications. So it's definitely a strong overlap, especially in the community, when infectious disease doctors have to be more knowledgeable about unique disorders. Thank you. So when to evaluate a PID, most of you probably have seen in your studies the 10 warning signs of primary deficiencies. I honestly think it's outdated, because if you look at that 10-point, it's very much focusing on infections. Ear infections, sinus infections, pneumonias, when you have problem with response to antibiotics, and the patient has deep-seated infections and thrush. So it's all like infection heavy, which I think is important. But what I would say, instead of like all these type of infections, is that there are just too many infections or weird infections. So when you have too many infections or weird infections, you really have to consider an immunodeficiency. But then we have 3 more other points that we should keep in mind. When you have a weird autoimmunity, a combination of unusual autoimmune disorders, if you see a patient with worsening lymphopenia, and I will come back to that later in the presentation, a case presentation that I have for you. And failure to thrive could be also a major issue in pediatrics and could be the first sign of an immune deficiency. So weird infections, I'm sure that this is something that you all know, so I'm preaching to the crowd. But when you think of bacterial infections, you really want to distinguish, is this patient having a broad spectrum infection profile or a narrow spectrum infection profile? If they have broad spectrum, such as upper and lower respiratory tract infections, CHEP and stuff, then you can clearly think about antibody deficiency syndrome and just go down that path and evaluate the patient for the antibody responses. But if you have a narrow spectrum infection with catalase positive organisms like staph, pseudomonas, or encapsulated organisms, you have to go down a very different path of considering an innate defect such as CGD or complement deficiency. So observing the patient's infectious history is very important. If, for example, the infections are primarily warts, viral infections such as warts, you have to think more of a T-cell deficiency route. But even the neutrophil lymphocyte syndrome, WHIM syndrome, can cause a lot of warts. When you see severe low respiratory infections, then innate defects could come in mind. And this is the RSV season right now in the Children's Hospital. We have a lot of patients who end up on ventilators, and they cannot wean off of the ventilator easily, and it's either RSV or multiple viruses at the same time. And we are evaluating these patients for innate defects because their antibody deficiency syndrome is milder, so it cannot really explain their decline. And then there are all these persistent GI bugs, which is a headache for most of us. For example, chronic norovirus infection or chronic GI diseases, Giardia, for example. We have a patient that I have a really hard time controlling his Giardia, and we have been working with multiple infectious disease services to help us. And then you really have to think of a combined immunodeficiency disease. When it comes to fungi, it's even more interesting. Candidiasis could be a T or innate cell defect. Then Aspergillus is very unique for CGD and hyper IgE syndrome, actually. And then you have these atypical fungi, such as pneumocystis, that is a giveaway for severe combined immunodeficiency. And it's very similar to when you think about your HIV patients, that when the T-cell count is extremely low, they can come down with opportunistic infections. And PJP can slowly creep on our children with initially just acute-pneumonia, and then later on hypoxia, and eventually they have to be intubated and then ventilated. When I'm mentioning this group of categories regarding infections, is there anything else that you would like to add in your consideration? I'm just curious, since I'm talking to the infectious disease crowd here.
This is Jamie Morano. First of all, thank you so much for speaking to us today. This is so valuable. Thank you, because we do have questions. This is great. We had an interesting case of coccidioidomycosis, actually. So I think endemic fungi, histo, we see in the oncological world, but we see a lot of coccidio. And the good Dr. Anthony Cannella and I kind of put our heads together and came up with kind of a tiered system for looking into immunodeficiencies, and we certainly love your input, but kind of like, first pass, second pass. So looking at, the IgA, IgG, and then kind of looking at the CH, 50, the complements and that kind of thing, the cascades. So we found that we do see a lot of endemic fungi, especially in the Southeast. And we found that helpful to have kind of a tiered approach in terms of what is most common in certain populations and differentials, and approaching it kind of like that. But that's the only thing I would add would be endemic fungi that we see a lot here.
I would love to have that conversation, because we see it on the pediatric side too, and I don't think we have enough of a tiered approach that we can provide to the physicians here. So if you have something to share, and I would love to have that conversation
Sure,
going.
yeah, happy to follow up. That's great. Thanks.
Great. especially with all the waters around us. Like we have a lot of patients who come down with even cryptosporidium. I don't know if you see that a lot in adults. Crypto, and then we have yeah, like I don't know why, but we have a lot of Pseudomonas infections. I don't know if you can explain it with the wetness of the area, or what do you guys see? Like just a lot of these I'm seeing it in lungs of children and sinuses of the patients and ear of the patients. Is this, you think, is particular also for the area, or only the cocci that you mentioned?
I can speak to that a little bit. We have a lot of Pseudomonas and injection drug users actually who use tap water, and I'll let the office folks speak up, but we also see that in skin diseases as well, and I think it's part of the water supply, but I'll let others speak out. But yes, you're right. We do see that in skin infections and injection drug use here.
It's great. So I'm definitely gonna like modify this slide for next year, and then we can start like building on it specifically for this group, because that helps us also to improve our own view of these patients. All right. Any other comments? Great. So then I'm gonna bring you to the weird autoimmunity, which you may not see under your practice, but you may see patients coming from hematology or rheumatology. And what we are learning is that if a patient have a combination of cytopenias such as ITP with hemolytic anemia, called Evans syndrome, or it is combined with a lymphoproliferative disease such as ALPS, then we really think that there could be a high likelihood of an underlying immunodeficiency. Also, patients who are refractory to first-line therapy, steroids and IVIG, and they keep on relapsing, could have combined immunodeficiencies or ALPS. So this is something that may not come to you with, they may have some level of infection, but looking at the history of cytopenias a bit more in depth and understanding the complexity of it could help you to decide whether you want to go down the route of immunodeficiency evaluation or not. I also have seen now several patients who had refractory rheumatological disorders, such as rheumatoid arthritis or Wegener granulomatosis, and we find in these populations unique entities such as C3 gain of function, REC deficiency. So again, this is just a combination of possible infections in combination with unusually refractory rheumatological disease, or if you have patients who actually have multiple autoimmune diseases. So when we have a combination of cytopenia with IBD and ALPS-like phenotype, and that takes us to this unique entity called the regulatory T cell defects or Treg defects. That's the largest category within immune dysregulation. We can identify these patients by genetic testing, and that therapy is extremely streamlined now with T cell directed therapy. So I would love to spend again just one session with the fellows and talk about regulatory defects. We did present last year to the fellows a CTLA-4 deficient patient, and that could be like a point of discussion again and grow on it. Again, complications after immune suppression and biologicals could be raising the eyebrows for the immunodeficiency, and those patients would have recurrent or worsening infections. They could have persistent B-cell lymphopenia after anti-CD20 therapy, or just have straightforward hypogammaglobulinemia, and we have to make a call, should this patient be treated or not. And when you look at antibody deficiency syndromes, you really want to distinguish, is it just low quantity or low quantity and quality? Low quantity antibody deficiency is like low IgA or IgG. It's relatively like uncomplicated, and you can replace with immunoglobulins. One of the genetic causes of it is BTK deficiency, which is called XLA. The low quality antibody is extremely frequent in our population, and they are called specific antibody deficiency or SAD. We don't have a lot of genes behind that, and these patients are primarily younger children or children who are having a couple of ear infections, sinus infections, and they do not get better just on antimicrobial prophylaxis. So we see that a lot, and we treat these patients, but I really don't have a lot of good understanding of what is behind the specific antibody deficiency. And then we have this sort of category where you have low quantity and low quality, which is again the CVID versus CID group. And I keep on mentioning that distinction because it's very important that you understand, is it just a purely B cell abnormality or is there a T cell component? And those patients would have a very high number of different genes that we could identify, and that would really help us to streamline their therapy. So I really encourage you to lift out CVID and CID patients in your practice, especially if they have non-infectious complications, and start considering looking at genetic defects, even if they are coming to you with no prior immune evaluation and no prior concern for immunodeficiency. So we discussed this already. And then we're gonna spend a little time on diagnostics, very minimal, so something that you can probably apply to your practice. I didn't want to dive into too many complicated diagnostic steps, but we will talk about antibody measurements, flow cytometry, functional assays, and a tiny bit of genetics. So antibody measurements, we all know that antibody levels change with age. So when you have a young child, initially the maternal IgG is influencing the baby's IgG level up to 6 months of age, and then eventually the baby's own IgG will kick in. And when you look at IgG levels, you really want to make sure that you are using an age-appropriate range. So this is right here. There is a nice table from Cunningham-Randalls, and for each age group, there is a different cutoff value. And I find it extremely important that you double check the age and the reported range for your patients, because it's not uncommon that a Quest or a LabCorp facility would just use a generic range. And if you have a patient who is coming below adulthood, like 15-year-old, they may have a very different range that is normal versus the adults. And when you look at the IgG levels, you can diagnose hypogam, you can diagnose transient hypogam of infancy, you can diagnose CVID and A-gamma globulinemia. So these are the diagnosis codes that you could use for your patients. Now, when we come to the specific antibody deficiency, you have to do a little bit more testing. So you will be looking at pre and post vaccine titers. This patient in particular had like a lot of low pre-vaccine titers. Our cutoff is at 1.3, independent of which lab is giving us a result. And then we want to see 4 weeks after post at least 50% serotype in protection level in 50% of the serotypes in pediatric patients, 70% in adults, and then the alternative approach is to look at least a 4-fold increase. I tend to follow up the levels one more time in 6 months, because it could be that the patient responds, but then they lose it very fast. And that is one variant of a specific antibody deficiency. So you can diagnose easily patients with SAD or CVID, and here you can do similar testing in tetanus, diphtheria, hip, and varicella. Tetanus and diphtheria tend to be like a pretty robust antibody response, so you very rarely see low titers, especially post-vaccine titers in patients, unless they have a major T-cell deficiency. But pneumococcal titers are often lagging behind, and sometimes even just a low pneumococcal titer could be meaningful in justifying the patient's eligibility for immunoglobulin replacement therapy. Any questions on the anti-pneumococcal response? I know that this always is a big discussion point for many of our attendings. I don't know if you guys are you using it a lot in your practice?
This is Michelle, one of the fellows. I just had a question. Why do they specifically use the pneumococcal as opposed to other vaccines that we have?
So it's a great question. And we sort of realized in our practices that the pneumococcal titers are probably like the least robust antibody response. So if you have a milder form of antibody deficiency, they're the one who could drop off fast or not be perfect. And the diphtheria and tetanus, because they're more T-cell independent, not as much of the B-cell independent responses, they tend to be like more steady for even immunodeficient patients. So the pneumococcal response, because the vaccine itself is a weaker antigen, and also mainly the Prevnar is of course T-cell dependent, but pneumovax 23 is B-cell. based, we can distinguish a milder form of immunodeficiencies easier with this milder vaccine.
We have seen a couple of our patients who have pneumococcal infections despite having both PCV13 and PPSV23. And those are not related to the vaccine because I get them typed. So we are seeing an encroachment of some of the pneumococcal strains going in to try and fill some of the niches that the vaccine is open for them. And I know CDC is very interested in that as well.
Mm-hmm. Are there particular serotypes that you think is going to be responsible for that, or it depends on the patient?
It seems to be more than one. One of my mentors when I was in med school did a lot of pneumococcal research and has Revcos filled with isolates from the area for about 40 years worth, and actually looked at with vaccines in the in that area, in the tri-state area in West Virginia. Mm-hmm. When the vaccines came through, infections fell. I mean, these were all invasive ones, not just looking at pneumonia, but what he saw was post-vaccine, other non-vaccine types started creeping in and causing illness.
Mm-hmm. Mm-hmm. Yes, and I think that's important that if there was a way to test broader, and do you have any other panels where you can test for a broader pneumococcal repertoire of like serotypes than what we have with the 23?
And no, to get them tested initially, you had to go through the health department and sent to CDC, but mm-hmm. Maury Musson told me, he's professor emeritus and retired now, but his lab is still going. He said, just let me know. And, you know, he said, I got a guy who's been typing them for 30 years, so he can get them typed for us. But that's about all I know with this at this point.
Yeah, this is very important because, of course, we are only looking at this mainstream, like Pneumovax response, but we don't really know what is, you know, possibly in the area that could be enhanced because of the, as you said, the vaccination helping with the rest of the strains. Good point. So then we also sometimes I use this avidity testing, which I don't know if you ever tried before. It basically shows how strongly the antibody is binding to the target. And if a patient has good vaccine response, but I'm still concerned, very rarely I look at this avidity testing. And what you can see sometimes that pre-vaccination, you would have a bit more of the low avidity antibodies to the serotypes. And then as the post-vaccination, the more robust avidity could be enhanced. And when this enhancement doesn't occur, then you can make like a very, very, like I would say, weak case for specific antibody deficiency, but it did work for me occasionally if I wanted to get a patient approved for immunoglobulins. But this is definitely not mainstream. It is sort of a bit of an esoteric test. And if you look at autoantibodies, of course, you can look for a lot of different types of autoantibodies with rheumatology, hematology. And I'm in particular excited about anti-cytokine antibodies. These are unique antibodies that could increase a patient's susceptibility for infections. On the left side, you can see that anti-interferon gamma antibodies can pose a patient for mycobacterial infections. And we share a case with pulmonology here who's from Thailand and had the anti-interferon gamma antibodies with her mycobacterial infections. You can have also to anti-IL-17, and that is linked to this chronic mucocutaneous candidiasis that I mentioned to you, or anti-IL-6 for staph, anti-GM-CSF or cryptococcal meningitis. And then on the middle part, which is sort of our interest in the lab, is the ones that that cause both infectious complications and immune dysregulation. And those are antibodies to interferon alpha. You have heard about it in the COVID pandemic. The patients who are developing anti-interferon alpha antibodies could be more susceptible to COVID. And we also see increased susceptibility to varicella. We link it to thymoma. And then also anti-IL-12 antibodies. So it's sort of interesting that all these acquired antibodies could be explaining maybe some of your patient's phenotype. All right, so we're gonna now move to the basic T and B cell subset immune phenotyping. It's gonna be only 3 to 4 slides, just to give you a taste of what you can do now on the T and B cell front. And I encourage you to consider this kind of testing in your patients. So this is, again, a reference from Dr. Shearer, who has created a nice repository for the normal ranges for many age groups and how many T cells and B cells they should have. And it is especially important in the newborn screening era, where we know that babies who are born should have a lymphocyte count of 5,000 versus an adolescent can go as low as 2,000 and still be normal. So you need to understand the age of the patient when you interpret a lymphocyte count and any of these subsets. And I have a quick case here of a child that I have seen at MGH back a few years ago. This was index case A, and he was a 23-month-old boy admitted with febrile seizures. And his grandfather B was a 70-year-old gentleman with CVID and GI disease. And they sort of felt that, oh, he has CVID, and they never really do lymphocyte subsets or additional testing. But what we also learned is that this patient's maternal first cousin died at 18 months of age from infectious complication. And that was back in the days, maybe like 15 years ago, when he had a bad myocarditis. So when you see this pedigree, what kind of disorder would you consider? What kind of inheritance? Would it be autosomal recessive, autosomal dominant, X-linked? Because it's skipping generations, the likelihood of X-linked is the highest. So there are probably maternal carriers of the gene, and then whenever there is a boy born and inherits it, he can have disease. So we consider an X-linked disorder here. And for a patient, one family member has CVID, the other had febrile seizures, but we don't know much about him. And he had recurrent infections, but nobody did a workup for him. So when we did our workup, we found undetectable IgG, A, and M in the patient. And looking at the grandfather, he also had undetectable IgA, very low M and E, and he was on immunoglobulins. And we had to really prove the disease by just looking at the B cell count. And this patient had near absence of B cells that basically put him into this category of BTK deficiency or XLA. And I think the interesting part of this story is that the grandfather has gone all through all of his life with a CVID diagnosis and GI disease. And against repeated infections, they just assumed that, oh, he has CVID. And nobody got to that point to get a B cell phenotyping on him, just to look at the T and B cell count. And had they done that, they could have seen that this patient is fully missing the B cells. So it's probably more like a genetically inherited immunodeficiency, and not even CVID, but XLA. So this is sort of why I think it's important to consider immunodeficiency even in patients who are already established, because you could help the diagnosis of other family members as they are born to the family. This is another example of an importance of B cell phenotyping. This phenotyping is a little bit more complicated because we are diving into the B cells and looking at two other markers, CD27 and IgD. And when you lose IgD and you express CD27, you basically have a switch memory B cell. So this is a B cell that would now mature nicely and start to be able to do IgG or IgA eventually. And that switch memory B cell compartment in an adult should be around 8%. So this patient is sort of missing this IgD negative CD27 positive population. And do you encounter patients when you would see a B cell phenotype and you would see that there are no memory cells? Have you been reading any of those reports? So I think it's very important to read. Go ahead. I'm hearing somebody speaking out.
No, I was just gonna pick on my second-year fellows. Have you guys seen anything in the past year?
All right. So, I mean, this is a great opportunity for us to show you this type of patients. And so this patient could, again, have a humoral immunodeficiency or combined immunodeficiency. And the nice thing about knowing that they have no switch memory B cells is that you really then can justify moving the patient further down the path of immune evaluation and say, this is not a typical B cell deficiency. It could be a problem with T and B cell interaction and class switching. So here I listed a couple of different basic panels that we use, and it wouldn't be too complicated to use a TGH as well. The basic lymphocyte panel just gives you the idea of all the basic subsets, CD4, CD8, CD19 B cells, and the NK cells. When you come to the memory immune panel, I really like that because, again, you can look at an adult who should have at least some like 30% naive, 70% memory. And if you have an adult who doesn't make any naive cells, then you have to consider a combined immunodeficiency. So I'm just gonna go to, because we are almost done. Do I have 5 more minutes or should I stop?
Absolutely, no, please.
Okay, this is another panel that, you know, I want to bring to the attention of the fellows here, what you can send out. So if you don't have something in your institution, you can send it out to Mayo. And Mayo is doing a very good job with the B cell panels to look for the switch memory B cells that I mentioned to you. And Mayo can also give you T cell data on naive and memory T cells. It can give you data on regulatory T cells. In Cincinnati Children's, we are doing OBS panels for the cytopenia patients. So you can order all these tests to start to like understand a bit better like what part of the immune system is affected. Okay, this is just an extended B cell panel from Mayo Clinic. And again, the switch memory cells that I mentioned to you, the CD27 positive, IgM, IgG negative is right here. And you can see that they will mark off that this is a low number and low fraction. This patient should have a much higher number of switch memory B cells. And then you have to consider evaluating the patient for combined immunodeficiency. In this case, this was an 8-month-old patient with CMV pneumonitis and hypogammaglobulinemia, no IgA and normal IgM. So and this is a good example of when you really just can't stop and say that this is an antibody deficient patient. The patient had hypogam, that's true, but now you have a CMV pneumonitis on the top of it. The two together is really pointing towards a T and B cell defect. So you can look for the absence of the switch memory B cells, and then the next step is that you can look for lymphocyte proliferation. You can look for the T cells and see how they do. And then eventually we did genetic testing for this patient, and he had a CD40 ligand deficiency. So he's a hyper IgM patient, and now he's actually transplanted. Okay. So there's one more test that I wanted to bring to the attention of your group called the MSMD panel in Wisconsin. This is the Mycobacterium susceptibility Mendelian disease panel, and it's a really great test to look for patients with tendency for bad mycobacterial infections and look for the interferon gamma production axis. And that could also lead you to eventually diagnose a patient with an underlying immunodeficiency disorder and make them qualify for interferon gamma therapy. All right, I'm going to finish up in the last 5 minutes with a case. It's a very short case, but I think it's very meaningful. I got this referral from Dr. Tara Seiko last summer, actually. And she's a former fellow from our program. And I sort of wanted to emphasize that how much our fellows can learn and take out to their private practice. So I got an email from her just a year ago in 2020, when she told me that she has a 34-year-old female in her practice now. And this patient has 3 to 4 sinus infections per year requiring antibiotics. In 2020, she was admitted for the first time, so that was like that year, for a bad pneumonia and imaging short bronchiectasis for the first time. When she asked a bit for her history, she had a little bit of a proximal joint arthritis. There was an extensive vitiligo and alopecia, and she actually had to be on valacyclovir for recurrent herpes infections, immune infections, and she also had problems with infertility. The immune evaluation that was done by her and other physicians in the area showed normal classes. Pneumococcal titers were low, therefore they had allergy. But eventually, like a year later, insurance returned back to 23, and the patient had a lymphocyte of 700 with a T cell count 97 of 27. So she was asking me how to evaluate this patient and worried about something beyond an antibody deficiency syndrome. So I'm in the group, this patient that you have here, would you stop and try to globulins or additional variation, and if you do, why would you do it? All right, we have very short time, so I'm gonna give you the answer. To me, the giveaway was the fact that the patient had a low absolute lymphocyte count that persisted even after the hospitalization, and the fact that the patient had recurrent herpes infections and non-infectious complications. So if you have a bit of that combination, you really want to push the evaluation further to the T-cell direction. So I actually told her, hey, Tara, great case. Maybe you can look into like genetic defects for some of the known genes. Think about naive memory T cells. Think about proliferation. Make sure that you understand EBV and CMV status with qPCR. And then the next day she said, well, you know what? I'm just going to order genetic testing because I'm like, it's impossible for me to do all these unusual T-cell studies. I'm in the private practice world. I can't really get that done. So within a month, she's like, well, I cannot get all of these testing done. So why don't we do the genetic testing? And bingo, the patient came down with a compound heterozygous REC deficiency that was basically inherited for both mom and dad. This is a split gene, and we could do that with diligence in the lab. And just this summer, this patient actually qualified for and she's the T-cell immune reconstitution. So this is an example of a patient who looks relatively benign in the community and walking around immunoglobulin therapy, but with all these subtle signs of the lymphopenia and the tendency for infections or non-infectious complications really raises the eyebrow of a colleague. They really push it through. They detect an underlying immunodeficiency that actually qualifies the patient for marrow transplantation. So again, the patient that we just discussed more likely had a common immunodeficiency because she's autoimmunity. She should qualify for long-term immunoglobulin. Her lung disease could be treated with anti-inflammatory treatment. We could consider, other biologicals. And at that time, when I did that presentation, I asked the question whether she should qualify for bone marrow transplant. And now, a year later, she's actually already transplanted. So this is my last slide, just to sort of summarize that in the era of newborn screening for SCID and unprecedented phenotypic diversity, overlapping disease phenotypes, and that span multiple specialties, we need to utilize advanced diagnostic studies, search for genetic cause, and do confirmatory functional assays to advance the recognition of these diseases, the targeted therapy, and potentially moving them to transplant. Thank you.